Hi, we'll discuss the questions of this CBT-1 for the FMGE exam. Okay, so these are 30 questions of surgery. The first question, let's see. A patient comes with a lump in the anterior triangle of the neck, 2 by 2 centimeter, and moves with the swallowing. So the lump which are moving with the swallowing are the thyroid swellings, not with tongue protrusion. Okay, so if it is not moving with tongue protrusion, means it is not a thyroglossal cyst. Which of the following is true of the fine needle aspiration? So when we do investigation by fine needle aspiration cytology, FNA sample containing colloid is suggestive of malignancy. That is wrong. Colloid is a benign condition. FNA sample containing follicular is suggestive of malignancy. See, follicular cells can be a follicular adenoma and it can be a follicular carcinoma as well. So just FNA cannot differentiate whether it is adenoma or carcinoma. We need to do a hemithyroidectomy and send the specimen for histopathology, and that will differentiate whether it is adenoma or carcinoma. Okay, so this is also wrong. FNA is useful in the diagnosis of papillary carcinoma. That is true. FNA can tell you it is papillary, FNA can tell you it is medullary, FNA can tell you it is anaplastic, but it cannot tell you it is follicular. So the same thing, FNA is useful in the exclusion. That is also wrong. FNA can neither diagnose nor it can exclude that it is a follicular cancer. Okay, so option number C is the correct answer in this case. The given image shows methylene blue being injected in the peritumor area like this. Methylene blue is injected here. Which of the following procedure is being performed? I am sure all of you have done this correct. This is sentinel lymph node biopsy. Okay, sentinel lymph node biopsy, in which you will inject the tumor, you will inject the dye. Suppose this is the tumor around the peritumor area, and now you can inject around the peritumor or periareolar also you can inject. Now this dye goes through the lymphatics into the axillary lymph node. 2 or 3 axillary lymph nodes you can biopsy, and depending on this biopsy report, if it is cancer, you have to do further treatment of the axilla, otherwise you can leave the axilla intact. Okay, so this is sentinel lymph node biopsy. Sentinel lymph node biopsy has proven role in carcinoma breast, in carcinoma penis, and in melanoma. Okay, so in these tumors it is very frequently done. There are other malignancies also in which these days people are doing sentinel lymph node biopsy, but these are the common tumors in which it is done. Next question. 19-year-old man brought to the emergency, and GCS is 3, that is the minimum. BP is okay, pulse rate is slightly high. Bilateral periorbital hematomas. Okay, so the patient is having this raccoon eyes. Okay, raccoon eyes. Bruising over right mastoid is Patel sign. Serosanguinous discharge from the right nostril and right ear, so there is CSF rhinorrhea, and ear means CSF otorrhea. What is the most likely diagnosis in this patient? Okay, so all these features, Patel sign, raccoon eyes, CSF rhinorrhea, CSF otorrhea, everything is going in favor of basal skull fracture. This is basal skull fracture. Leafords 1, the fracture occurs just above the alveolus and the hard palate. Leafords 2 is the pyramidal fracture involving the maxillary and the orbital floor and root of nose. Extradural hemorrhage will may or may not have these features. So this is classical basal skull fracture. Next question. 35-year-old man brought to the emergency, and signs and symptoms of simple pneumothorax. Which of the following anatomical landmark is not useful for safe triangle? Okay, the safe triangle for putting the ICD is lateral border of pectoralis major, anterior border of latissimus dorsi, and a horizontal line at the level of nipple. Okay, mid-clavicular line is not a boundary for this triangle of safety. That is our answer. Otherwise, in general, like the specific point where you would put the ICD is 4th or 5th intercostal space, just anterior to the mid-axillary line. Identify the triangle given in the image. So this triangle, which is found by this point, is the cystic duct. Okay, so this is cystic duct. Okay, this is the second and third part of the duodenum, and this point is body and neck of the pancreas junction. This triangle which is forming here, it is known as gastrinoma triangle or Passaro's triangle. Okay, gastrinoma's triangle or Passaro triangle. Okay, it is used for localization of gastrinoma, which is a neuroendocrine tumor of the pancreas. Because of this, there is a decreased pH and gastric peptic ulcer formation can occur, diarrhea can occur, and this helps in identification. Okay, the gastrinoma will be present somewhere in this triangle only. The most common site is in the medial wall of the duodenum. The commonest site is somewhere there in the medial wall of the duodenum. Next question is 60-year-old man undergoes neck dissection and 2, 3 and 4 lymph nodes were removed and the jugular vein, accessory nerve and sternocleidomastoid were preserved. Okay, so all the 3 structures are preserved and only level 2, 3 and 4 is removed. This is lateral selective neck dissection. In modified radical neck dissection type 1 and 2, we remove lymph nodes from level 1 to 5 are removed. But in 1 we preserve one structure like cranial nerve 11. Okay, accessory nerve, cranial nerve 11 is preserved. In 2 we preserve 2 structures, cranial nerve 11 and internal jugular vein preserved. Lymph nodes we remove is same. In modified radical neck dissection 1 to 5 are removed. In selective neck dissection we'll preserve some nerves also. Some lymph nodes also, like in posterolateral we are removing level 2, 3, 4 and 5 removed. In lateral we are removing 2 to 4, like the question is about level 2 to 4, so this is a lateral type of selective neck dissection. Okay, so the selective neck dissections are mostly done as a prophylactic dissection for those cases where the lymph node involvement is not there, high risk cancer and the lymph node involvement is not there. The correct procedure, see this is a Ryle's tube. Okay, I'm sure it is not difficult to identify Ryle's tube or the nasogastric tube. Okay, there are 3 lead balls present here and there is this radio opaque line. Okay, these will act as a radio opaque marker, so that can be seen on the X-ray. So Ryle's tube, you will put, the patient should be sitting with neck slightly flexed. And how much you have to insert inside, that you will measure by measuring the length from nose, ear and xiphisternum. From nose to ear to xiphisternum means that much inside it should go from the nose for reaching the tip at the stomach. After it goes there, you can aspirate to confirm, you can push air and put a stethoscope in the epigastric area to confirm that you are in the correct side. This is about a burn which involves hair, face, neck. So head and neck becomes 9%, anterior chest is 9% and both upper limbs is 9 plus 9. So the total percentage is 36%. 36%, rule of 9 given by Alexander Wallace. Okay, so it was very straightforward. If there is anterior chest as well as posterior chest, then it will become 18%. Okay, it is 9 anterior chest, 9 anterior abdominal wall, 9 posterior chest and 9 posteriorly the abdominal wall. But is not included in MELD score. MELD score is model for end stage liver disease. Model for end stage liver disease. Okay, 3 things are seen. The mnemonic is CBI, creatinine, bilirubin and INR. Okay, albumin is not included. MELD score is used to main use these days is to put the patient on the priority list. I mean the patients of liver transplant who are waiting. So you can put these patients on the priority list and the person who was having higher MELD score will be put higher up in the waiting list. So they will be given priority. Okay, so that is model for end-stage liver disease. Treatment of a 2.5 centimeter staghorn calculus with mild hydronephrosis. Okay, open surgery. So these days for the renal stones we are not doing. ESWL is usually reserved for less than 2 centimeter stone. It is 2.5, so it is, ESWL will not be successful in this case. URS is ureteroscopic removal of stone. Ureteroscopic removal. This is mainly done for the stones which are present in the ureter. Ureteric stones, especially in the lower 1/3 of ureter, URS is used. 2.5 centimeter staghorn calculus means it is in the pelvis. PCNL should be done. Okay, percutaneous nephrolithotomy. Percutaneous nephrolithotomy. Okay, see, if the stone is less than 5 mm, less than 5 mm, or you can say 0.5 centimeter, then you can wait and watch. 5 to 10 mm, ESWL is the good technique. 10 to 20. In this size group, you can go for either ESWL or retrograde intrarenal surgery. More than 20 millimeter, PCNL. Okay, so this is 25 millimeter, 2.5 centimeter, that's why PCNL. Most common functional neuroendocrine tumor of the pancreas. See, if suppose this functional word is not there, if they ask only the most common neuroendocrine tumor, then that is a non-functional tumor. Non-functional adenoma, it can be a pancreatic polypeptide producing tumor, neurotensin producing tumor. But now because they are asking most common functional, then the answer should be insulinoma. Okay, all these are functional tumors because they are producing something which will cause some symptom in the patient, so that's why these are functional. The same thing if they ask most common functional neuroendocrine tumor in MEN syndrome. So in multiple endocrine neoplasia syndrome, the answer would have been gastrinoma. But because they are asking in general, the most common functional neuroendocrine tumor, it is insulinoma. Identify the grade of bed sore which is shown in the image. So the bed sore is showing bone. So if the depth is going up to the bone, it is grade 4. Grade 1, there will be only erythema and edema. There will be only edema. You will not see any skin necrosis. In 2, there is partial thickness skin damage. In grade 3, there will be full thickness which is going up to the subcutaneous tissue but not beyond fascia. Grade 4 goes beyond fascia, which is involving maybe muscle, bone. That is grade 4. And sometimes you will see a ulcer on which there is some kind of scab is present. Okay, scab or eschar like hard layer. So until unless you remove this scab or eschar, you will not know how deep it has gone. So these kind are known as grade 5. That is unstageable, because to know the stage, you need to know how deep it has gone. Next question, which of the following is a common characteristic of both keloid and hypertrophic scar? Okay. Common characteristic of both keloid and hypertrophic scar. There is often familial tendency to both. Familial is keloid, not hypertrophic scar. They extend beyond the boundaries of the original wound. Only keloid extends beyond the boundaries. Hypertrophic scar does not occur beyond the boundaries. They occur most commonly in young patients. This is true statement. Okay, usually keloid occurs in young patients because young patients have more, you can say, collagen, and this is mainly because of the collagen. They occur late in the wound healing process. Late, usually keloid occurs late. Hypertrophic scar occurs early. Okay, in both the cases, there is excessive collagen, and both mostly seen in young patients. In elderly, you will hardly see any keloid or hypertrophic scar. Okay, so option A is the true statement. Next question, 30-year-old man involved in the road traffic accident and mildly anxious after losing a significant amount, tachycardia, tachypnea and oliguria. Okay, and now they are asking which degree of hypovolemic shock. Hypovolemic shock has grade 1, 2, 3 and 4 depending on the blood loss. Okay, so anxious patient, heart rate 113, urine output 20 ml, and this all goes in favor of class 2. Class 2 hypovolemic shock, in which the patient loses 15 to 30% of the blood. Okay, in 1 there will be, if we see patient will be alert, in this case 1, the heart rate will be less than 100. Okay, respiratory rate will be 15 to 20 and urine output is usually more than 30. In grade 3, the patient is usually, in these cases, drowsy, and the urine output becomes more or less than 10 ml, and the heart rate will be more than 120, and tachypnea will be like around 30 to 40. And grade 4, so everything is like very severe. This is very severe kind of shock. The heart rate will be more than 140, urine output is almost nil, and tachycardia like 140, respiratory rate will be more than 40. So this question is classically describing class 2 hypovolemic shock. Identify the type of knot in the given image. See, for the knot I told you, you have to see this loop. Now in this, if you see this particular loop, you can see one thread is going over and one thread is going under. So this type of knot is a granny knot. Okay, in reef knot, both the threads will be going symmetrically. Either both are going above the loop or below the loop. So this is a granny knot. In surgeon's knot, the first one is double, you can say half hitch. So that's why, that is how it is not surgeon's. Okay, so it is very classical granny's knot. All of the following except one is the contraindication for organ donation. Organ donation, CHAMP. Okay, Creutzfeldt-Jakob disease, HIV with opportunistic infections, active systemic sepsis, malignancy, and past history of malignancy in last 5 years. So in malignancy and past history of malignancy, the basal cell carcinoma and squamous cell carcinoma are exception because these are low grade tumor. So you can take the organ from these people. Okay, so active sepsis you cannot, I mean this is a contraindication. Cancer is contraindication. Melanoma is contraindication. Basal cell carcinoma is not a contraindication. That is our answer. Okay, all of the following except one. Okay, so they are asking which is not a contraindication. Identify the type of drain shown in the image. This drain is Jackson-Pratt drain. Jackson-Pratt drain, which is a type of closed suction drain. Okay, Jackson-Pratt drain and this Romovac, Minivac, all these are closed suction drain. Okay, the answer is this. Corrugated drain is a open drain. It is a open type of drain which opens directly into the dressing of the environment. It is not attached to any bag or any small container. The investigation of choice in a patient with suspected recurrence following breast conservation surgery is, breast cancer, mainly the investigation, we do the triple assessment. We come with the history and clinical examination, then radiological, and then tissue diagnosis. Radiological investigation is mostly mammography for more than 40-year-old and ultrasound for less than 40-year-old. But this question is the patient already underwent breast conservation surgery and now you are suspecting recurrence. So in that case, you have to differentiate whether it is after the breast conservation surgery, whether it is only a scar or a recurrence. And for differentiating scar and recurrence, the investigation of choice is MRI. Okay, so MRI is the investigation to differentiate from a scar and recurrence. In a patient with breast cancer, chest wall involvement comes in T4A. Involvement of all of the following except serratus anterior, yes. Intercostal is yes. Ribs is yes. Pectoralis major and latissimus dorsi is not chest wall involvement. Okay, so T4A is chest wall. T4B is skin involvement. In skin, the things which will you see is you will see the ulceration, satellite nodules, you will see body orange appearance. Nipple retraction and dimpling is not skin involvement. Okay, and T4C is when there is both chest wall as well as skin involvement, and T4D is when it is directly a inflammatory carcinoma. Okay, which is mainly having erythema and edema involving more than 1/3 of the skin over the breast. Which one of the following is not used for the reconstruction of breast tissue? Okay, so reconstruction of breast tissue means after doing the modified radical mastectomy, what kind of the flaps are available? This is tram flap. Okay, so transverse rectus abdominis can be pedicled or it can be free. Both can be used. LD flap can be used for like reconstruction of the smaller size breast. This is tram free flap. Okay, pectoralis major myocutaneous flap you cannot use. Pectoralis major is here only. Okay, and you cannot use that for the breast cancer patient. This flap is mostly used for the reconstruction of the head and neck area. Identify the specimen below. This is the open gallbladder specimen which is showing multiple yellow flakes, these cholesterol crystals inside, which is a very typical of strawberry gallbladder, also known as cholesterosis. Okay, another name for this is cholesterosis. Cholesterosis. Carcinoma gallbladder, there will be a mass. Cholelithiasis, there will be stone. Polyps may there will be small, small nodules or polyps you can see on the gallbladder mucosa. Which of the following statement regarding skin grafting is incorrect? Partial thickness include the epidermis and part of dermis. That is true. These grafts are also known as split skin graft or the Thiersch graft. Full thickness include epidermis and the whole dermis. That is also true. Full thickness is mainly used for large defect. This is the wrong statement. Okay, full thickness is used for the small defects. For large defects, you need a partial thickness because the donor area in the full thickness is not going to heal on its own. You have to do some kind of suturing there. So that's why full thickness you use only for the smaller defects. Full thickness has better cosmetic outcome because the contraction is less, the color match is good. So this statement is also true. The false statement is C. Mark the correct statement about inflammatory bowel disease. IBD is inflammatory bowel disease that contains ulcerative and Crohn's disease mainly. Crohn's disease has skip lesion. That is true statement. Inflammatory bowel disease has genetic predisposition. That is also true. There are it has familial tendency. It runs in the family. There are certain genes, not two CART15 genes, like these genes are common in Crohn's. Crohn's is mucosal and ulcerative is transmural. This is false. This is rather the other way down. Ulcerative is mucosal and Crohn's has transmural involvement. Crohn's is curable fully. That is also false. Ulcerative colitis can be totally cured if you do a total proctocolectomy and ileal pouch anal anastomosis. So 1 and 2 are the correct statements. So option number A. 24. The most common ectopic tissue found in Meckel's diverticulum is gastric. Okay, so the common ectopic tissue gastric, then pancreatic, then colonic. Okay, in more than 50% of the cases, the mucosa inside the Meckel's diverticulum is gastric. We call it as heterotopic or ectopic type of mucosa. Because of this, there are chances of ulceration, there is chances of bleeding, perforation in this area. The risk of wound infection in clean contaminated wound is 2 to 10%, you can say less than 10%. 1 to 2% is in clean wound. 15 to 20% in contaminated. And around 30 to 40% in dirty wounds. Dirty wounds like if there is pus, if there is gangrene. Contaminated is when there is major breach in the sterile technique, early perforation, early accidental wound. Clean wound is when there is a minimal inflammation, infection, and the hollow viscera is not entered, like thyroid surgeries, hernia, breast surgeries. Clean contaminated is when the hollow viscera is entered with minimal spillage like you can say elective GI surgeries, appendix surgery, gallbladder surgery, those comes under clean contaminated. Which of the following instrument is seen? This instrument is a Morris retractor. This is a Morris retractor. Jawl is a self-retaining small retractor used for the thyroid surgery. The knee retractor is also small. It has retracted part on both the ends. Devers is also used as compared to the Morris retractor in many abdominal retraction surgeries. Next question, 40-year-old female with pain and jaundice. You are suspecting cholangitis. Which of the are part of Raynaud's pentad? Okay. So see, initially when there is cholangitis occurs, patient will have pain, fever and jaundice. Okay, so this pain, fever and jaundice is Charcot's triad. Pain, fever, jaundice is Charcot's triad. Now in this case, if the patient goes into septic shock, then there will be additional hypotension and there will be altered consciousness. Now it becomes Raynaud's pentad. Okay, so fever, jaundice, hypotension, altered mentation. 1, 2, 3 and 4. Okay, hypertension is not seen, so option number C. Next question, while operating a case of inguinal hernia in a male, sac is located medial to the inferior epigastric artery. So if the sac is medial, this is the inferior epigastric artery, this is the deep ring, this is superficial ring, and if the sac is present here, means it is a direct inguinal hernia. And the best surgery is hernioplasty, that is a Lichtenstein. So this is direct hernia and Lichtenstein repair. Next question, a middle-aged male presents with episodes of hematemesis, and there was a history of hematemesis few days back. Endoscopy shows that a jet of blood is coming from a tiny defect in the mucosa, very small defect, and this is 2 cm from GE junction. So this is a very classical case of Dulafoy's lesion, in which within 6 cm from the GE junction there is a large submucosal vessel, usually more than 3 mm diameter. So when it pulsates, because of this pulsation, it will erode the mucosa anterior to it, and now when the gastric acid comes in contact with it, it will erode the vessel wall, which will cause this bleeding. Okay, so this is a very typical Dulafoy's lesion. Watermelon stomach is gastric antral vascular ectasia. That is, you will not see this kind of bleeding there. Very little bit microscopic bleeding occurs, that is leading to anemia. Most common type of bariatric surgeries. See, bariatric surgeries are the weight reduction surgeries done for patients of morbid obesity. I'm sure you know morbid obesity means when the BMI is either more than 40 or more than 35 with comorbidities. Okay, so all the options, Roux-en-Y gastric bypass, gastric banding, sleeve gastrectomy, duodenal switch, all are bariatric surgery options. These two are the restrictive surgery. This is mainly a malabsorptive surgery. and this is mainly a restrictive surgery. This laparoscopic adjustable gastric binding and sleeve gastrectomy are purely restrictive surgery, and the most common is sleeve gastrectomy. All over the world, including India, the most common type of surgery done is sleeve gastrectomy. Okay, so thank you very much and best of luck for your examination. I hope you have done well in this CBT-1.